thank you. So, I don't know, I was always the pain talk, where I was the last guy to speak. Now today I'm the last person before lunch. So, I think though I want to thank Gary for inviting me, and hopefully my presentation will also set up what's going to happen later in the afternoon, especially what Malcolm's going to talk about and what Stefan's going to explain as well. When Gary invited me to present, since that time I've had some type of I don't want to say existential crisis, but trying to think about where does this really fit in. And this is something you really can't explain in 30 minutes, but how do I figure out and relay to you, how can we do balanced care and try to distinguish who's benefiting and who's not, and what are the complexities with that? Because obviously when we start talking about tapers, and I've seen it as a clinician, some of the problems that our patients face with that, maybe we need to take a deeper dive into what's really the opioid doing to the patient, and then understand how comprehensive care works. So I decided to change the title, should have been Identifying Patients Who Do Benefit from Chronic Opioid Therapy, and identifying patients who may benefit from chronic opioid therapy. So this is very complex. And so again, just hopefully this talk won't have a lot of slides on with data, but more just getting us to think a little bit more about the complexities of our patients. So we're going to talk about considerations around opioid therapy, extending beyond opioid analgesia. I don't think it's supposed to computers. Pull up the wrong one for me too here. But in my disclosure from the other slides, I'm sorry. We're going to talk about focus and emphasis. Should we focus and our emphasis change? Who's not a good candidate? What is patient-centered care? And then what are those tools that we can use? Where can we use those tools more effectively? And it's great to be up here with being preceded by Aaron and others that have done a lot of work in this area on outcome tools. How do we really use those tools the right way when we know there's limitations? And I'm going to try to frame it around two quick patient stories. So I think, we've seen this slide already this morning. There's, I know we're familiar with the three ways of the impact of opioids and overdoses on society. I think where we are now is this fourth wave of pharmacovigilance. Pharmacovigilance is huge. It's the state of looking at a drug, in this case opioids, and its impact on society. And then from that, putting together evidence-based patient-specific guidelines and structure that we can improve patient care. So that's where we are now. I think this fourth wave of pharmacovigilance, whether it's patients that need to stay on opioid therapy or who need morphine therapy or medication management in itself. If we look at some of the problems, and I think this is actually looking back at maybe where we were, and I see this on the physiatrist. I run training services for the health system. We do injections, we have an addiction specialist, we have interdisciplinary pain rehabilitation programs together. So we get patients referred from all over, some on low doses of meds, some not on any opioids at all, and some patients who've done opioids for many years. And what I've seen from that, from a number of different patients, is maybe the focus was on the left, where it was just opioids mostly, and that didn't work, and then it's center of the pain clinic. And the non-pharmacologic part was very small. And how do we change that? Okay. And it was good to hear Aaron talk about the National Pain Strategy. And the same week that the CDC guidelines came out was the National Pain Strategy, and a lot of us were more involved in that. And that actually gives a pretty good breakdown of how we can really improve and transform care for patients. And it focuses on where I think we should be, which is here. How do we maybe still retain opioids for those patients who benefit, but how do we integrate these other non-pharmacologic treatments instead of really, in a sense, I don't mean to be negative today, but it's giving these treatments lip service and not really following up on and integrating that. And then all of a sudden we look at an opioid dose as more equivalent, and we're going to solve it by decreasing more. So again, that's where hopefully the future is going to go. Why is treating pain such a challenge? Okay. I don't know about you, but I won't make practice notes out of the way, but sometimes I really feel like we're dying because they're all. Maybe we need to repent. You guys remember saying this right here? Okay. Just think about that. Was our whole issue around opioids that we put all our eggs in one basket? What I saw were patient pain, and the opioid itself was a marker of just poor pain care. Dose up if they're not doing better, they look more depressed or anxious, keep increasing the dose, and we're going to find this dose that works. And is that the wrong kind of approach? Or is it just not just the opioid part? We really need to be looking at what the patient is experiencing. If you look at most discussions about pain, I like this quote that talks about the definition has always been kind of controversial. I think of pain as a threat to the biologic integrity of the person. What we're treating is actually the suffering the patient's going through, how that's changed that person. But if you look at pain itself, there's always this, quasi-philosophical discussion about the mind-body connection. The author finally opts for dualism, then there's parallelism, and some kind of monism. So this is complex. And if you think of pain, pain is sculpted in this kind of mosaic of factors. And that mosaic of factors would be depression, anxiety, catastrophizing. What's the underlying cause of the pain? Their history. That's why this is very complex. And so what I want to do just over the next 25 minutes is cover these considerations. And I was trying to tie this down into 4 different areas. The pain uniformity myth, negative affect, which I think is really going to be important when we start trying to determine kind of appropriateness for patients and what's really happening with them. Opioid receptors, and nothing better than presenting after Jane, who did a great job explaining the complexities around addiction and those pathways. But how does that fit into what the patient's getting? And then talking about some of the pitfalls of unidimensional tools and how that can be improved upon. Well, the patient uniformity myth kind of implies that patients that share the same disease are homogeneous. And we know that's not true. There's so many differences with patients. Okay? But unfortunately, sometimes I think where my fear is that we're applying that uniformity myth also to patients on opioids. They're on opioids. Well, each patient, like every one of my chronic pain patients is very different. So we want to be careful with that uniformity myth. Because we know patients are heterogeneous. There's those physical, cognitive, behavioral, and other affective contributions to their pain. Even though they may be reporting to us a pain score. We're using that pain score to kind of justify our continued treatment. So the second was negative affect. Negative affect, if you think of pain, pain is an aversive physical experience and emotional experience. And negative affect has been described a number of years ago where it kind of puts together depression, anxiety, distress. In the past, they talked about neuroticism. And in patients with pain, also are anxious. There's anger. There's disgust about what's happening in their life. And what I want to touch upon is some of the research that's come out recently on negative affect. And I think the patients that come in or that aren't doing well on opioids, or they're not sure what to do, they're struggling. It's that negative affect that has really been missed. And how can we do a better job of understanding that? So a negative affect, in a number of studies, correlates with increased pain intensity and poor function. It's been studied in low back pain patients, surgical interventions, even interventional procedures. That's been a strong predictor of bad outcomes. Cancer postoperative pain shows that the magnitude of negative affect symptoms correlated with higher doses of opioids, and we're starting to see other studies showing the same thing. And I'm going to skip some of these slides because this is an older slide deck here for the sake of time. So negative affect, this was a study that Jay Wasson did in Boston, and I was in Pittsburgh. They actually took patients that were on with chronic pain. Some of those patients were opioid naive, some were on low doses of opioids. They took them off opioids and then put them into, titrated them either on morphine or oxycodone. And they grouped the high negative affect patients, and here they described that they had a correlation, they had a combination of high depression, anxiety, and catastrophizing. They took and looked at those high negative affect and the low negative affect to see if there was any predictability there. The results of the study, in over a 3 to 4 month period, they titrated them up. The doses were about 40 to 50 morphine equivalents, not very high. The high negative affect group had higher daily morphine equivalent and lower pain relief. Okay? The high negative affect group had greater rate of opioid misuse and greater opioid side effects. An interesting part, when we looked at the negative affect, the high negative affect groups, they had actually higher improvement in depression, better than their pain. And so again, is there something else going on? What the opioid is giving them that's leading to that use of the medicine? If we do look at the brain, the brain itself is kind of an output of what's happening in the body with regards to pain. It's not measuring or demonstrating the magnitude of the sensory impulse. If you take 5 people with a joint replacement surgery that's pretty similar insult to the nervous system, they have very different responses to pain. Okay, so again, that there's cognitive changes, contextual changes, genetic differences. All of that's going to frame how they respond to pain. And the same thing's going to happen when we're talking about opioids and that analgesic effect. What else is happening in the with that person. And so we like to explain to patients too is that, yes, pain, opioids can help with analgesia, but we know the other side effects that are listed on the left. Some of those they can become tolerant to. But on the right, I think, is where we as clinicians kind of struggle, or patients struggle. It's the reinforcing effects of the opioid. In some cases, reducing anxiety, increasing boredom, increasing self-esteem. And I get a lot of patients that say they take their Vicodin 4 times a day, it quote unquote takes the edge off. And they say they have a half-point reduction in pain, yet they want to do that. They've been doing that for the last 10 years. What are they really getting out of that? Jane actually went through this. If you kind of correlate that with us looking at the pathways for addiction, and this is the 3 cycles of addiction, the basal ganglia is very much important with reward. The extended amygdala with stress reaction, fight or flight. And these patients chronically, just with pain, their fight or flight is elevated. And I think, Jane, her fight or flight levels in her extended amygdala went up when her video didn't work, but she did a great job of recovering. But just that kind of stress and what that does to the brain. So again, I wanted just to underscore what is that opioid actually doing? Because I think just focusing on the pain numbers can be problematic. This is actually work by Valentino and Amor Vapo. It really takes us, I think, to where that question may be answered. It may help define even what Jane was talking about with those patients that are chronically using opioids that may not meet criteria for addiction, but are having problems. And this is going over the 3 different opioid receptors. We have a mu receptor, the delta receptor, and the kappa receptor. And for many years we've been told that most opioids work on the mu receptor, and we've kind of concentrated on that. But a lot of work has been done with genetic and animal models, pharmacologic studies. And this actually kind of shows that there's some differences. These 3 receptors are pretty homologous. They look alike. And a very small part of that receptor is different, and that's where there's the differences in response. So the mu receptor is primarily responsible for euphoria and stress coping, but the kappa receptor, again, these other receptors show us the differences with this kind of continuum from the hedonic or pleasurable rewards of opioids and the mood effects down to the right. And so the kappa receptor here is responsible for dysphoria. It actually can inhibit the mu receptor. It can increase stress and negative affect. The delta receptor on the other side is more anxiolytic and actually has antidepressant effects. And so is that the effect that patients are getting from the quote-unquote opioid response? And then we take that away, and what is emerging without the opioid? Or is this going to be very from patient to patient? Because I do think every patient is responding differently to opioids. So again, this just gives us that understanding of the complexities of what the analgesia is actually doing. And so I also wanted to comment on, obviously, the need for multidimensional pain tools. In our system, we use PEG across the board with our primary care and all of our specialty clinics because it helps to pick up on enjoyment of life and general activity. But others have been studied as well. The key, though, is how do you use those? Do you use those with all your patients? And how do you educate your patients how to use those correctly? And so I think it's important just to touch upon the using tools in a patient-centered manner, or don't use them, or teaching clinicians to spend time with patients on how they're using their tools. And I think a lot of our patients get questionnaires, they fill them out real quick, they don't really concentrate on it. The physician never comments on the questionnaire or even the results. And we sign it and put it in the chart. Versus how do we stop for a couple minutes and say, you marked this on your questionnaire, what does this really mean? And really start to use the tools. Otherwise, like I say, don't use them. In the state of Washington, we've spent the last couple of years now, a year and a half, working on our new pain rules. This is from the pain rules from the commissions that we're using PEG. That should be standard with our pain rules. So looking at pain, enjoyment, and enjoyment of life and function. Thank you, Aaron, at all. And so, but even that is only as good as how the person uses that tool. So here's an example. The PEG. Well, what number best describes your average pain in the past week? What number best describes how you're doing in the past week? What number best describes during the past week how pain's interfered with your general activity? So clearly that's not what I think the patient's experiencing. Now, are they mad at me because I'm late, I haven't been in the clinic yet, I'm 20 minutes behind, and they're mad and they want to show that they need to get help? Or so, again, how do I stop and tell the patient, we're going to try to assess your pain, but we really need to use this tool effectively? Or Or maybe in this person, I'm not going to ask them to fill this out. So again, the tools have to be used the right way, or we have to spend time with our patients actually educating them about that. And so again, then the patient understands when we're doing short-term goals and long-term goals, maybe this is the tool that's going to help measure that. So I wanted to comment, this is from the HHS Interagency Task Force, and they talked about, it was released in May, the importance of a biopsychosocial approach, and even within that they talked about opioids and the gaps in that kind of approach at the primary care level, even at the specialty care level, of looking at function, looking at quality of life, and using tools the correct way. So I do think we have a lot of best practices in this part of the country. I've been in Seattle for 5 years, I came from Illinois. There's a lot of structure in the state. We have the ABG guidelines, we have our new pain rules in the state, as well as the CDC guidelines. Still though, I think the emphasis really needs to be on awareness of these guidelines. Because clinicians are still, I think there's a lot of inconsistency of them understanding this, because they're pretty straightforward, they're very rational, yet they're not really being used. So I wanted to comment on a couple of patients. These are two of my actual patients. Mary on the upper left, who's a high-dose, low-functioning patient, and then Donald, who's on the right with the hat on, who had moderate dose medications with pain. His function was somewhat stable, but just to kind of characterize some of the issues that I face as a clinician trying to help him. But understand that patients can present in so many ways. You can have a low-dose compliant patient that's high risk. You have a recreational user, or the patient is getting rewarding or anxiolytic effects from the opioids, and it becomes a struggle to treat that patient. So I was going to try to frame my discussion about Donald as a new start. Really, he's a patient that was unable to take other kind of medications and has significant medical problems, and then was on opioids. So let's say how he presented and how we worked with him. And then a patient with chronic opioid therapy was referred to us, Mary, and some of the challenges that she faced, and how we looked at were opioids effective for her, or were there other interventions to use as part of the treatment plan. So again, what is the biopsychosocial approach? And obviously, besides giving it lip service, doing a good physical exam. I think many of our patients refer to us minimal exam, and they're kind of marked as a chronic pain patient. There's not really a lot more intervention after that, and they're kind of on autopilot. And then we just figure that we're going to continue that type of treatment. So besides a good patient history, really performing a good physical exam to try to better understand what's happening. And then you can actually educate your patients better and actually do the right thing. How do we risk stratify patients? In the state of Washington, that's actually a rule now for subacute and chronic patients. But risk assessment is key, not just for predicting adverse effects from opioids, but I think those same risk tools can be used to predict chronicity and help us to identify those patients that are higher risk or meet those risk criteria need more comprehensive treatment. So I think it's kind of easy to say that opioids may be part of the treatment plan, but not the plan. Even though that sounds simple, I think many of the patients that are referred, it was just the opioid. And we forgot other treatments that could be helping these patients. And even if we're considering tapering, it's not just going to be how do we start decreasing their dose. How do we really understand what's happening with that patient? How are we going to use other types of treatments as we're doing the taper? And again, taking this to a different level. So the CDC guideline, this is just going over the 12 recommendations. I think we've all seen different derivations of this, and Debbie will obviously discuss that today. I think, again, the first 3 recommendations get less emphasis, where we really need to be focusing and educating our clinicians. The opioids are not the first line for routine therapy for chronic pain, but if they're going to be used, they need to be used with other types of treatments. Establish and measure goals of pain and function, and then discuss benefits and risks of opioid therapy. So I think those, again, are somewhat doing lip service. How do we teach our clinicians to really use this and discuss that with patients? So we'll go over Don. Don was a 63-year-old. He has severe rheumatoid arthritis, lumbar spondylosis. I've been treating him for about 3 years. He's since had L3 sacral infusion, chronic renal disease, COPD. He's on chronic prednisone. Rheumatology decided no other medications for him except steroids. He's also got diabetes, so very complex patient. He's a retired lumberjack. He came to us, actually was on, at that time, was on 15 milligrams of oxycodone 3 times a day. Prior to that, he'd been on about 36 milligrams of Dilaudid. He was taking it 4 times a day. And that was for about 8 to 10 years. And then we switched to methadone for about 6 months. And the methadone actually helped him. But no one wanted to write methadone, so he was converted, went to another clinician, and they put him on oxycodone, and he was referred to us. He had high anxiety, depression, multiple physical exam findings related to his back pain. He had multiple joints affected by his rheumatoid arthritis with contractures. So we focused with him first on a patient-centered history. What we learned from him was his goals were to walk more with his wife, to be able to hunt, and to be able to start doing some work in his garage. Those were his goals. His expectations, he was upset and frustrated because he'd been pushed around by different clinicians and didn't think people really believed him and they thought he was just a junkie. And he thought before, when he was on this medicine, he would take it 4 times a day with all his pain for about 1 hour, and he would do that 4 times a day. He was anxious and upset and just didn't know what was going to happen. And then he actually thought that the methadone, he said, well, that medicine kind of helped me actually twice a day, and my pain was a little lower and I felt a little bit better. So there's a lot of confusion in his mind about his care and about what he needed. So we did a risk assessment, and our risk assessments include the PEG, his morphine equivalent. We use the opioid risk tool, hearing screens. We have a system we walk patients through with regards to their risk stratification. So his opioid risk tool was scored as a 6, so he had a family history of alcohol use. He had had history of alcohol use in his 20s, but had been clean. So his score was 6 or moderate risk. At that time, when we risk stratify in our system in Swedish, we risk stratify patients. First, we look at their morphine equivalent and their opioid risk tool score, and that's their first adjustment. So in his case, he was medium and medium with his ORT. But then we adjust after that for the medications that the patients are taking to be put them at high risk for overdose and his medical comorbidities. And if they have 2 points or more, we can actually grade up. So he started at moderate risk, but because of all his medical complications, we actually graded him up to higher risk. And so again, just using somewhat of a system that we can look at patients not just based on their ORT or their morphine equivalent, but those other medical conditions that are really going to put them at risk, as well as medications. His PEG score we worked on, and he was actually really good at understanding that. He had multiple hospitalizations. He was septic, had all sorts of medical conditions you would assume with the patient with his medical diagnoses. We did a lot with educating and working with his wife to really communicate with all the different physicians who were working with him. We actually converted him back to taking methadone 10 milligrams twice a day. And through all the different hospitalizations he had, he pretty much stayed on the same dose. We worked on his mood with antidepressants, with SSRIs that seemed to help. We stabilized him and made him more compliant with his CPAP for his sleep apnea. But again, this was an ongoing relationship with him. We were seeing him every 2 months at least. And with his management, like I think a lot of our patients, his goals actually changed. His goals changed after he was in the hospital and was released. He unfortunately had other problems with regards to his mobility problems, but we were able to still have a conversation with him about what does he want, what are the goals, what are the things he wants to do. So again, these cases are complex, but I just want you to understand that's what we should be teaching our clinicians. How do we follow up with these patients? How do we adjust what our goals are and adjust their treatment? So just for the last couple of minutes here, looking at these risk factors, and I think a lot's been talked about with aberrant behaviors and family history, psychiatric comorbidity, age, trauma for aberrant behaviors. But what are the risk factors for poor opioid response? Is it psychosocial factors? Is it negative affect, which patients may be presenting with? Genetic characteristics, lack of knowledge. And, a big emphasis in our clinic with our interventions are on education. Our patients don't understand their body. They don't understand stress. And just that type of education intervention, and I think Aaron alluded to, just even at the primary care level, basic education of patients also is going to help with their pain management. So how do we put this all together? As well as with patients that are presenting with poor response to opioid therapy, are there incongruent expectations of what they think the opioids should do? And is there diversion, which I think also has been kind of missed in a lot of these discussions. So in our state, part of the rules now talk about when to consider tapering, so we can give that guidance to our clinicians. I highlighted two of the different ones that I think are interesting in this next case. Patient experiences of deterioration in function. Patient is receiving escalations in opioid dose with no improvement in pain or function. And I think that's tough because is it, again, just the opioid? What is really happening with the patient? And so I'll just kind of briefly explain. Mary was a retired nurse. She's got scoliosis, very severe lumbar spinal stenosis. She also has rheumatoid arthritis. She had been referred to us on 10 milligrams of oxycodone twice a day. She said it helped her for a very small amount of time. It made her dizzy, it just didn't make her think well, but it was quote unquote the only thing that gave me a little relief. And so what we learned from Mary, and actually Mary participated in one of our pain rehabilitation programs. The question in paper wasn't that hard to her. She wanted to get off the oxycodone. But we actually put her into a treatment program to learn other skills while we started decreasing her meds. Versus some of these patients, just to start tapering them without giving them other skills, I'm not sure what their success rate is going to be. And so she participated. We have a modified pain rehabilitation program. It's 3 days a week for 5 hours a day. Physical therapy, occupational therapy, psychology, relaxation training. She had had physical therapy in the past. She had never spoken to a behavioral health specialist. She had never had relaxation training, and she had never seen an occupational therapist. And so she learned basic pacing techniques. She learned about her body. She learned, we do a lot on pain neuroscience education about stress and how that increases your pain. We trained her in Tai Chi. She learned 3 or 4 different Tai Chi movements that she did every morning. So over those 4 weeks, we slowly took her off her oxycodone. She learned these other skills. Her function significantly improved. Her pain score was down by about 1 point. She still held on to that. But she learned a lot more things. It was so much easier during that time to then slowly decrease her medication. And then we worked on other types of pharmacologic interventions. So I think the key here with her case was it's the opioid came in as the marker that she wasn't doing well, but we really need to give her other tools. And then it was a lot easier to decrease her opioid. And actually, since that time that she finished the program, she had a progression in her spinal stenosis with more radicular leg pain. So we've been treating that. She continues to be very active with her home exercise program. So this is not just a one and done with a lot of these treatments with our chronic pain patients, but this is chronic disease management. And so that was just the kind of story about her. That again, it's not just the opioid. The opioid was the marker that she needed better care. She was very open to this once it was delivered to her. So, who does benefit? I don't know. Like I said, I think we have to look at all those different factors. We have to look at what's the opioid actually doing. Hopefully having a better understanding of the analgesic effects, plus all those other changes that are happening. So if we go back, what does repent mean? Repent from the Greek word is metanao, means change your mind, change your thinking. Okay, so it's not ask for forgiveness. We all want to do the right thing for our patients, but how do we change our thinking with these patients? Again, and I'm a little worried about the whole tapering idea. Tapering is good, but we've got to look at these patients individually and understand what's really happening. There are maybe some patients that need to stay on opioids or maybe need to stay on those higher doses. But how do we do this in a rational way? So we talked about the future state of integrating opioid therapy as an option. And then pain, uniformity myth, we talked about negative affect. Again, the complexities of the mu opioid receptor, delta and kappa, and how that works, and to be thinking about that, and really looking at, moving beyond pain as a visual analog scale with a vital sign to doing patient-centered assessments. And that's going to involve multidimensional questionnaires, spending time with your patient, but really starting to try to understand what's really going on. So, again, pain management, again, in pharmacovigilance, we talked about that state we're in now and trying to figure out where do opioids fit, where does pharmacologic therapy fit. But again, it's got to be just really a small part of bigger pain management, whether it's interventional, medical management, interdisciplinary care, complementary, and having addiction medicine. All of those kind of combined, as well as on the left side, integrating it with the community, with primary care, with the emergency department. How do we get those things